Okay, so let's dive straight in. If you're a child care provider, you probably had that moment, that sudden worry. A child gets a rash, maybe their lip looks a bit swollen, and your mind just races, doesn't it? Is this minor? Could it get serious?
Yeah, and we know this is a big concern. At Paul Kenny Training, we get asked about managing allergic reactions all the time. It really highlights the need.
Absolutely. So welcome to this deep guide first aid. We've put this together specifically to tackle those questions, those worries you might have.
Think of it as a focused study guide, helping you get up to speed on first aid for allergies in your setting.
Exactly. Especially focusing on adrenaline auto-injectors, the AIs. We want you to feel knowledgeable, confident, not overwhelmed.
And the information we're using, it's solid. It comes straight from official sources, gov.uk, the MHRA.
That's the Medicines and Healthcare Products Regulatory Agency.
Right. And specific guidance from the Department of Health on AAIs in schools, too. So, it's properly grounded stuff.
Okay, so what are we actually going to unpack today? Well, first up, recognizing reactions. Mild versus the really serious anaphylaxis.
Then we'll really get into the AAIs themselves, their role, how to use them properly. That's vital.
And we'll look at the rules around schools having spare AAIs because the principles there apply pretty much everywhere in childcare.
Yeah, and what that means for staff responsibilities, too. We've pulled out the key bits, things we know people ask about from our training.
So maybe just ask yourself now, how confident do you feel distinguishing those reactions and knowing exactly what to do in a severe case? Hopefully, this deep dive will really boost that confidence.
Let's start with recognition then, because like you said, it's not always clear-cut.
No, a little rash might seem like nothing, but you need to understand the whole spectrum. From those milder things, swollen lips, itchy mouth, maybe a tummy ache.
Right through to anaphylaxis, which is potentially life-threatening.
And even those milder signs need attention.
Oh, definitely. Don't ignore them. They could be an early warning, or they might need sorting themselves like giving an antihistamine if it's on the child's plan. Vigilance is key. That's something we stress.
So what are the big red flags?
Sure.
The signs that tell you this is escalating towards anaphylaxis. The guidance gives us the ABCs.
Right. A good mental checklist. A is for airway.
So what are we looking for there?
Things like a persistent cough, maybe their voice sounds hoarse, they're struggling to swallow, or you can see their tongue is swollen.
Okay. And B for breathing.
Yeah, difficulty breathing. It might be noisy, wheezy, or, again, that persistent cough can be a breathing sign, too.
And C, consciousness.
This is about changes like persistent dizziness, the child looking pale or suddenly floppy, getting really sleepy out of nowhere, or actual collapse, losing consciousness.
And the word persistent seems important there.
Very. It's not just a fleeting thing. These are ongoing signs. The MHRA also mentions general things like dizziness, being really tired, or confused as well. All worth noting.
Okay, so if you see those milder signs first, what's the drill?
It's pretty straightforward. Stay with the child, obviously. Get help if you need it. Find their AAIs just in case.
Give antihistamine if the plan says so.
Yes, if it's part of their documented care plan. And definitely call the parent or emergency contact. Keep them in the loop. Even this proactive step for mild signs is a common training point.
That makes sense. Early monitoring, early action.
Exactly. It can sometimes stop things getting worse.
Okay, now the really critical bit. You suspect anaphylaxis. ABC signs are there. What next? This is where speed is everything.
Absolutely. First step, positioning. Get the child lying flat, legs raised. Immediately.
Why raise legs?
Helps blood flow back to the heart and brain. Anaphylaxis can cause a sudden drop in blood pressure.
Right. And the only exception is if they're really struggling to breathe.
Yes. Then you can let them sit up slightly, gently. But the key message, and we've really hammered this home in training, do not stand them up.
What about pregnant individuals?
They should lie on their left side. But for everyone else, flat, legs up. Standing them up is dangerous. The guidance warns it could even lead to cardiac arrest. It's that serious.
Okay, so position correctly. Next.
Use the adrenaline auto-injector without delay.
And the guidance is really strong on this, isn't it?
Unequivocal. If anyone or more of these signs are present, and crucially, if in doubt, give adrenaline.
Don't hesitate, even if you're not 100% sure it's anaphylaxis.
Exactly. MHRA says use it promptly if suspected. Better safe than sorry. And remember, sometimes anaphylaxis hits without milder signs first, especially breathing problems with a known food allergy. Don't wait for a rash if they can't breathe.
That's a really vital point. Difficulty breathing in a known allergic child? Use the AAI.
Yes. The risk of delaying is far, far greater than the risk of giving it unnecessarily in that moment.
Okay, AAI administered. What's the very next step?
Call 999 immediately and tell them anaphylaxis.
Be clear about what's happening.
Yes. Then, stay with the child, keep them lying down, do not stand them up. If they stop showing signs of life, start CPR.
And call parents again.
Yes. Phone the parent or emergency contact, and, very importantly, if there's no improvement after 5 minutes,
use the second AAI.
if one is available, yes, use the second dose. That's why the recommendation is always to carry 2.
Right, we'll come back to that. So the 999, call any practical tips, things people ask about.
Yeah, good point. Give clear directions. Postcode is essential. If you give that second dose after the first call, wing 999 again to update them and just confirm help is definitely on the way.
Maybe get someone to wait outside for the paramedics.
Good idea. To flag them down, and when they arrive, tell them everything. Known allergies, what you think triggered it, and exactly what time you gave the adrenaline.
That detailed handover is crucial for them.
Definitely. Helps them take over smoothly.
Okay, let's focus a bit more on the AAIs themselves. EpiPen, Jext. What exactly are they doing?
Basically, they deliver one single, preset dose of adrenaline, straight into the muscle, usually the thigh. Designed for emergency use to fight anaphylaxis. Understanding them is core to the training questions we get.
And the MHRA says use them fast if you suspect anaphylaxis.
Without hesitation. Get that adrenaline working quickly to counteract the reaction. Early use really improves the outcome.
And who can actually give it? Because people worry about that.
This is so important. Anyone can give adrenaline in an emergency to save a life. You don't need to be a doctor or nurse. The rules empower you to act.
That's really empowering for childcare staff. Don't feel you can't act.
Exactly. In that life-threatening moment, you are authorized. You should act.
And we mentioned it, but let's underline it. The advice to carry 2 AAIs.
Yes. Strongly recommended by both MHRA and NICE. Always have 2 available for anyone at risk.
Because the first might fail or not be enough.
Precisely. That backup, that safety net is vital.
And there's updated advice on positioning after giving the adrenaline, too.
Yes. The latest MHRA guidance reinforces lying flat, legs raised, pregnant individuals on their left side, and crucially, stay lying down even if you feel better.
Don't jump up too soon.
No. Only sit up gently. If breathing is really bad, then lie back down ASAP. The absolute rule. Do not stand up. We make sure our trainees know this updated advice.
Okay, and just to repeat that 5-minute rule?
Yes. If no clear improvement after 5 minutes, use that second AAI if you have one. Don't wait longer. Time is critical.
What about keeping track of the AAIs? Expiry date.
Oh, vital. Regularly check the expiry dates on all AAIs. An out-of-date one might not work properly. Make it part of your routine checks. Remind parents they need to get replacements from the GP or pharmacy well before expiry.
And if you think a device is faulty, maybe it didn't fire right.
Report it. Use
Yeah.
the yellow card scheme run by the MHRA. Report any suspected defect and keep the device safe for investigation. It helps keep everyone safe.
Good to know. That reporting helps maintain standards.
Absolutely. It's a simple thing anyone can do that makes a real difference.
All right, let's shift focus slightly to AAIs in childcare settings specifically. The documents we looked at focus a lot on schools, but the ideas apply more broadly, right?
Definitely. The principles are the same. A key change came in 2017, allowing UK schools, England, Wales, Scotland, certain types in NI, to buy spare AAIs without a prescription.
For emergency use.
Yes. It came about because schools and parents were asking for it. It's something we discuss a lot in our Paul Kenny training sessions.
Is it compulsory for schools to have them now?
No, it's not mandatory. It's discretionary. But the guidance really encourages schools, and by extension all child care settings, to consider having spare AAIs as part of their first aid setup for better preparedness.
Okay, but you can't just use a spare AAI on any child, can you? There are conditions.
Very specific conditions. First, only for a child already known to be at risk of anaphylaxis.
Right.
Second, you absolutely need both medical authorization confirmation from a doctor, A&D written consent from the parents, specifically allowing use of the spare AAI.
And that needs to be documented.
Clearly. In the child's individual health care plan, or maybe a BSACI allergy action plan if that's all they have, and crucially, the spare is only for when the child's own AAI isn't there, or it's broken, or you just can't use it quickly enough.
So it's a backup, not a replacement for their own prescribed pens.
Exactly. A critical backup for emergencies. The consent rules are there to make sure it's used safely and appropriately for the right child.
How does a setting actually get these spare AAIs?
You need a formal request, signed by the head teacher or manager on headed paper. It needs to state the setting's name, why you need them emergency use for known risk children, and how many you need.
And pharmacies can supply them, but you'll likely have to pay.
Yes, pharmacies can supply them now without an individual prescription, but they don't have to provide them for free. So factor in the cost.
In choosing which spare to get, brand, dose.
Good question. The guidance suggests maybe getting the brands most common among your existing allergic children. For consistency, easier staff training, less confusion in an emergency.
Makes sense. And the dose.
There are age guidelines from the Resuscitation Council UK. Under 6 years old, it's 150 micrograms. Ages 6 to 12, 300 micrograms. Over 12, it's usually 300 or 500 micrograms.
So you need to think about the ages of the children at risk in your setting.
Exactly. Maybe even get medical advice to pick the most suitable spare doses for your specific needs.
The guidance talks about an emergency anaphylaxis kit. What should be in that?
It's basically a dedicated box. Should have the spare AAI, clear instructions on use and storage, the manufacturer's leaflet.
A checklist for expiry dates.
Yes, a monthly checklist, plus clear info on how to get replacements, a list of children authorized for the spare AAI, and a log sheet to record any use.
Good idea to keep it with an asthma kit, too.
Yes, often recommended, as allergies and asthma can go together.
Okay, storage. This sounds critical. Where do you keep all these AAIs, spares, and personal ones?
Needs to be safe, central, unlocked, and accessible to all staff. Basically within 5 minutes, not locked away.
So like the school office, staff room.
Potentially. Somewhere easy to get to, out of reach and sight of kids, but instantly available. If your setting is large, you might need kits in different locations.
And label the spares clearly. Keep them separate.
Absolutely vital. Clearly mark them spare and keep them physically separate from the children's own prescribed AAIs. Avoids any mix-ups in a panic.
That accessibility within 5 minutes feels really key for anaphylaxis.
It is. Every second counts.
Yeah.
And clear labeling prevents errors under pressure.
Okay, let's talk about staff responsibilities. This comes up a lot in our questions. Can staff be forced to give an AAI?
No, legally they can't be required to. It has to be voluntary. But the guidance strongly encourages staff to volunteer for this role.
But training is then essential if they do volunteer.
Absolutely crucial. The more staff trained, the better. And not just theory, proper, practical, hands-on training with trainer devices for the different types of AAIs.
Online stuff isn't enough on its own.
It's supplementary, maybe for refreshing knowledge, but it doesn't replace practicing the physical steps. The guidance also suggests having designated staff.
People specifically trained, who are the go-to in an emergency.
Exactly. You need enough of them to ensure someone's always available, covering breaks, absences, etc.
But it's not just about those designated people, is it? All staff need some awareness.
Yes, huge point. Everyone needs basic awareness. Recognize the signs, know how fast it can happen, understand you give adrenaline quickly, know the policy, where the kid is, who the designated staff are.
And someone needs to be in charge of checking the expiry dates regularly.
Definitely. Recommended to have at least 2 named staff responsible for monthly checks and getting replacements sorted. Using the manufacturer expiry alerts is a great tip, too. Helps stay on top of it.
And if an AAI is used, what needs to happen then?
Record everything. Where, when, who gave it, the dose. Inform parents immediately. And this is non-negotiable. Any child given adrenaline must go to hospital for monitoring.
That comprehensive approach, training, awareness, clear roles, sounds like the best way to create a safe environment.
It really is. It ensures a coordinated, fast, effective response if the worst happens. And the recording and follow-up is vital for the child's care.
Just quickly on liability, staff are generally covered if they act responsibly.
Generally, yes. Settings should have insurance that covers staff administering medication in good faith, unless there's serious misconduct. Local authorities often cover maintained schools. Academies and others need their own cover or might use the DFE scheme.
Reassuring for staff to know they're protected when doing the right thing in an emergency.
Yes, it is.
Okay, let's pull this all together. Key takeaways, thinking about those common questions we get at Paul County Training. First, recognize anaphylaxis, know the ABCs, but remember, it can be sudden.
Second, don't hesitate with the AAI. If in doubt, give it.
Third, call 999 straight away. Say anaphylaxis.
Fourth, position correctly. Flat, legs rise, don't stand them up.
Fifth, have clear policies, train your staff properly. And sixth, always aim for 2 AAIs for children at risk. Those are the absolute basics.
And if you understand these guidelines, have good procedures, get staff trained, You really are much better equipped. You can handle these emergencies confidently. It's a vital part of your professional toolkit.
We really hope so. And please do look further. The documents we base this on have links, spare pens in schools, Allergy UK, Anaphylaxis campaign, NEC guidelines, loads more info there.
Definitely worth exploring. And maybe take a fresh look at your own settings policies after listening today. See if anything needs tweaking.
Right. So here's a final thought for you, something to mull over.
Considering how incredibly fast anaphylaxis can happen, what small practical changes could you make in your daily routines, in your emergency plans, in staff awareness?
To make absolutely sure your response would be the quickest, most effective it could possibly be if a child in your care had a severe reaction.
Something to think about. How can you shave off those crucial seconds?
Definitely gives you food for thought. Well, thank you for joining us for this deep dive. We hope this deep guide first aid has been useful and has helped answer some of those important questions we hear so often at Paul Kenny Training.